And I think everyone has the questions that were presented just a moment ago by Eric, and they're here on the screen, as you can see. The first thing I'd like to do is just to let you know that I'm going to take notes on this screen so you can all see the notes as we go through this. Dr. Andy Beinman is going to lead the discussion with you. And then one thing I'd like to do is to ask one of the commissioners if you would use these notes to report back in a 1 to 2 minute summary back to the large group and to the public when we're done. So I wonder if we could get a volunteer from one of the commissioners to do that when we're done. Sarah, was that you raising your hand? You're on mute, so get off mute so we can hear you. Can we get
with the chat, not volunteering?
Okay, good. Can we get a volunteer from one of the commissioners? Sarah already said no, but we need somebody. So Anthony, Bill, Peter, or Jim? Okay, I'm going to call on one of you to do it. Anthony, would you be willing to summarize the discussion for the group?
I think we need all the commissioners need to unmute. I think you were put on mute when you moved into the breakout. So please just unmute. Yeah.
Thanks, Andy. Anthony, can we get you to volunteer?
Reluctantly, yeah.
All right.
That's the spirit, Anthony.
I appreciate it. Okay, so let's get going. We have 22 minutes before we're going to be called back to the main group. So, Andy, do you want to get us started?
Yeah, great. Well, thanks. I'd just love to hear commissioners weigh in first on this first question. And you just heard Rick Kroenig talk about some of the design features that we're going to address related to unified financing. And so just want to know, what design elements should be included within unified financing to reduce disparities and increase equity. So really just throw out your ideas and we'll write them down.
How do you want us to just raise our hands or go to a participant?
There's only a handful of us. So Bill, why don't you go ahead, or we'll see if that just works for the commissioners to be able to speak. Go ahead.
Well, if Bill's not going to go, I'll dive in. Bill, do you want to go?
Okay. I think the question is obvious. To achieve equity, you want to cover everyone, and you want to give everyone at least equal benefit package. If you want to achieve even true equity, you may even favor the most vulnerable groups, like the ones which have more comorbidity and so forth, as well as other social conditions. So I think the principle of establishing equity is moving toward uniform. One is universal coverage. Second principle is minimum is equal benefit package for everyone, and with possibility, if you can afford it, to favor the most vulnerable group, high-risk groups. And then the third principle is you want to have it financed equitably. This is, we're only talking about one side, which is creating a coverage and benefit people. But at the end of the day, somebody has to pay for it. And so there's an equity issue on who is going to pay for this program. And that should also be done on an equitable basis. That is, people who can afford to pay should pay more, proportionally more. In other words, some kind of progressive tax. That would be few principles I would lay out to achieve equity.
Terrific. Other commissioners?
So this is Peter, and I would just add, if I could, two things. I totally agree with everything that Bill just noted. Is one, there needs to be a process in the structure to assess the impact of social determinants, because we all know, and this is a savvy group, that between 60 and 70% of the inputs into health are not care. It's about issues of income, issues of where people work, and Sonia's note about people of color being more apt to be essential workers is why they're more apt to be exposed to the coronavirus. I mean, that's a great example of that. So we need to have that as a factor. The other is we need a design element that makes sure we're actually measuring and clearly identifying people and their outcomes by race, by ethnicity, by language, by income, and other factors. So we're understanding what are the contributing factors that we need to be addressing and moderating, as Bill well addressed.
Great.
This is Sarah. I have a lot to say on this, but I think number one, we have to cover everybody. We have to get away from this employment model. It's just structurally inequitable, but also, I mean, there's industries that have shed a third of the jobs. We have unions where 98% of their members are laid off. All of a sudden, they're losing their benefits and are in this gap. And so we just have to have this consistent coverage no matter where you are to address inequities. And then also, I noticed that there's not a breakout or not a session that's on workforce, but that does seem like a really important element, because it seems like there are models to get at how do we deliver equitable care, like was said, to the most vulnerable, and to the ones who have, and to the individuals who have really been neglected in our current system. And how do we do it in a way that is cost effective? There's models, Unite Health in Las Vegas, which is a healthcare system that is partly run by the union, has a whole model of community engagement. There's a lot of different levels. They recruit union members who speak the language of other patients, who are culturally competent, who are from the same backgrounds, and are able to kind of address those issues, who can do home visits, who can make sure people are doing adherence to their medication, who can also see if there's any other needs that they have. So that kind of medical home, which gets into the social determinants, because there's so many other services that are needed. And I also think, mental health, like we have to do something about mental health, because it is so core to what's going on in this country, and to addressing equity, and to looking at what is the stress and mental and physical impacts of racism. And I have a lot more, but I'll stop there.
Great. I'm going to turn to another commissioner, but Bobby, I'm just wondering, you're taking these wonderful notes, but maybe you're going off the page and we can't quite see. I wonder if you could just scroll up a little bit so we could see where you're still typing. And
Sure. Thank you, Andy.
yeah, perfect. Yes, great. Okay, so any thoughts from Antonia or Anthony or Assemblyman Woods?
Well, this is Antonia. I think it's a given that the goal is to cover everyone. So I think, and to provide the same level. But I think in covering everyone, we have to determine and acknowledge where people are today. And the inequities of our current system has a large group of people that we're seeing right now with COVID that have certain conditions that are going to require a lot. So it's not an issue of covering everyone, because that's the goal. That's why we were created, to cover everyone. The question is, as you move people into the system, however it is, you have to acknowledge that for certain communities, preventive care, educational care, is going to be really critical important. You know, and we have to consider, as has been said, the social determinatives, because if you live in a poor community that do not have access to markets that provide affordable, you know, sort of a healthy food, the consequence is the diabetes, the obesity, et cetera, et cetera. So to me, it's sort of all of the things that have been said. I'm working with the assumption that our goal is to come up and recommend a system that covers everybody. And the real challenge for me is going to be how do we afford it, and how do we transition from what we have to the new system? And so to me, affordability is really, to me, the most important issue, because I think everybody agrees we should have a system that provides everyone. And I'm not in the medical field, but what I see as an employer is that we have certain systems that we can look to see, you know, how they do it. Like, for instance, in California, Kaiser is a system that's affordable, that my employees like. They like the consistency. Now, I'm not proposing Kaiser, but I'm saying there are systems, many systems already, that are providing healthcare to a very large number of individuals. And it appears that they are doing it in a way that it's affordable. So anyway.
Great, thank you. Anthony,
Yeah.
or something? Yep.
So, I mean, I appreciate this discussion and I agree with much of what has been said. I mean, obviously, universal coverage, there's a lot of what we're talking about that by its nature will be more equitable. I mean, you can't design a more inequitable system than the one we have now in terms of leaving people out, in terms of how regressive health benefits are, how the sickest have to pay the most in the way that cost sharing is mostly designed, things like that. So moving toward a universal system, moving one where there's unified benefits would be foundational. But I think it's also important to recognize that universal is foundational, but it's not sufficient. That if we're going to deal with some of the equity issues, we need to have, there are communities that have specific problems that are going to need specific solutions to address the inequities that are in the society as a whole, whether it is the structural racism that people have been talking about over the last couple of months, and frankly for decades, but or whether it's just the specific needs of whether it's the LGBTQ population or of children. I know, you know, in the last meeting there was some of the children's groups were talking about the sort of specific programs and needs in EPSDT and others that, you know, for those groups that we can't. So this I think is an important principle, this sort of targeted universalism, where we have everybody have access to to same benefits and all that, but that there are these specific things. And then that goes to, I think, a second point I want to make, which piggybacks on what Peter Lee was talking about, which is not just a tracking of what's going on about how care is delivered, but also specifically what's going on in terms of sorry, I lost my thought for a second. We need to be able to hold the industry accountable for that. If they are not reducing healthcare disparity, if they're not providing quality, then what's the mechanism? I think the reason why that I support single payer and other reforms is because it provides a lever to provide accountability. And the question is, how do we make that accountability? What happens to a hospital or to a medical group that is not actually providing equitable care to different populations once we get that data? Is it a financial incentive? Is it what are the levers that this unified system could use? Right now, we don't have that accountability because of the fragmentation of our system. But with a unified system, how do we actually put that accountability into place?
Great. Now we're at about a little past the halfway point, so I think we should probably transition to the other question. I do want to give Assemblyman Wood a chance if you want to say something a little about question one, or whether you might want to help us get into question two a little bit, which really has to do more with, you know, how would we know it if we were doing equitable care? What would be the best way for us to track that? What outcomes should we use, and who should we be tracking them for, and so forth? Maybe we've already gotten some clues from the commissioners about this, but I think it would be helpful to do that. Assemblyman Wood, would you be open to kicking this off?
Well, I was just going to comment on first question, and then I'm
Sure.
listening and taking note of the great comments, and I really appreciate the input that's coming here. I would say that one of the key factors for me is if we're going to reduce disparities and increase equity is workforce related. I represent a largely rural area, and so we have a workforce that is not equally distributed throughout the state, and so we have to find a way to get providers to our communities, and not just providers, but also the infrastructure to support that. Just because you live in a rural community doesn't mean you should have to have a lower level of healthcare. And so we have to find, as we build a system, ways to get providers to our communities. And that means physicians and nurses and mental health providers, you name it. And that's one of the huge challenges we face, certainly in the rural North Coast that I represent. So that's my 2 cents at this point, and happy to go on to the next question if you wish.
Yeah, great. So anyone want to kick us off with the next question about sort of how would we know it when we were delivering it? How would we know we were making the progress we want to make on equity and reducing disparities?
Craig Simmons here. Can I jump in? Hello?
I'm sorry, who's speaking?
It's Craig Simmons. Can I jump in?
No, this is just for the commissioners right now.
Oh, okay.
Well, this is Peter Lee. I'll get the ball rolling, and I mean, I go back to some of the basic classics of IOM, the safe, timely, equitable, efficient, patient-centered, and the steep, the 6 IOM. I think I'm missing one of the E's. Equitable, efficient. Someone help me out with the other E. But there's a range of measures that we need to be looking at, and it's not quality includes cost-effective to patients and the system. Quality includes that it's safe, and we should be having those baked in ways that are collected and measured, not as add-on work for clinicians, but baked into how they deliver care. And you know, there are some effective measures now around chronic care, but they should cut across the range of where people need care. And I totally agree with Sarah's note. It needs to be in issues of behavioral and mental health. It needs to be in prevention. It needs to be in people with chronic care, but also people with very complex conditions. And so it needs to be the spectrum of measures that address the spectrum of what people's care needs are.
Mm-hmm.
Great. Yeah, that other E you came up with was effective, so thank you for that.
Thank you, effective. Thank you very much. I knew you'd be able to correct me on that. There you go, Andy.
Well, you said it yourself, Peter.
I did. I knew I came out at some point.
Great. What do others think?
Well, I think he has really clearly enumerated. I mean, sort of, how do we know when we have? Well, for instance, the measurement of good health, the rates of diabetes, you know, I mean, the measurements shouldn't be that difficult, the outcomes. It's how you get there and how you measure getting there. But, you know, I think you know, like for instance, I would assume that we would want everyone to be vaccinated on the, you know, whatever we agree, preventive care. We would want to know that people are having, you know, sort of periodic examinations to make sure that, you know, illnesses are caught early. I just don't think that that's a difficult area once we agree, you know, and I would defer to the medical people. What is considered good health?
So if I may, just Peter, just chiming in one more time, then I'll shut up, is I wish it were that clear and easy, but I'll give the example of in behavioral health, we do not have many really good cross-cutting measures on whether people are getting the right behavioral health at the right time. And that's an area, so the issue of having a system that bakes in measures, so from a patient's perspective, their understanding about their level of depression, is it improving, things like that. We do a pretty good job on controlling high blood pressure measures and diabetes measures. But outside of a handful of chronic illnesses, we actually, sadly, many years in, don't do a good job. And I would hope a unified financing system would also be a unified system around collecting better measures of how we're doing.
And I agree. And I think the reasons we don't have good measurements on behavioral health is because it hasn't been offered to people. It's only the wealthy that have been able to access that. And there hasn't been much focus from the medical profession, in order to be able to provide that. So I think that that's an area where for the first time, we're actually mentioning mental health to be as critical and as important as physical health. And I think that that's one of the things that we should definitely include, is that the importance, the equal importance of physical care as well as mental care.
Let me jump in here. I think I agree with everything has been said. I think one principle is to try to measure progress. You cannot set absolute standards, but you look using some measurements to see how much progress we're making toward the equitable and efficient effectiveness, what Peter brought out. I think I would just add one point. What has been talked about here is all focused on health care then. You're not talking about the social determinants. And that's a much tougher issue. One of the major determinants, I'm an economist, and we do these studies. One of the major determinants is the social status and the income of the people determine their health. And I think I'm in support of their trying to deal with the social determinants, but I think it's really you're taking on the whole societal problems, which is on income, jobs, creation, wages, social status, education, which is a major determinant of health. So I think maybe the commissioners, we can think about initially, can we agree on we're just going to focus on measuring on the health part, or do we want to actually look at the whole thing, which I think is, as an academic, I can tell you there's really very little measurements other than income or things can measurable. Even on job creation, what kind of job you create to make it more equitable. Instead, I will argue here, I will support Assembly Wood's point. You can measure progress. How much are we really getting the providers to the underserved areas? So it's not just insurance and coverage, but actually the services are there, and as well as being efficient, effective, and safe, and so forth, which Peter, you have articulated.
That's great. I just want to interject here. We've probably only got about another minute and a half. This has been a fabulous conversation. I'm sorry it's going to have to end because I love the interaction, but maybe one or two more commissioner comments real quick.
I think we didn't hear from Sarah on the second question, did we?
Yeah, Sarah, you have any comments, or Anthony?
Yeah, I mean, I will say one, in terms of care that is equitable. I mean, I would go back to the presentation that we saw from Dr. Angel, like just looking at the racial inequities of the impact of the virus. Let's start there and see if this system is correcting some of the damage that our existing system has already done. I think that would be an important measure, going back to focusing on the most underserved and vulnerable. And then I'll say, going back to high quality, I think a measure of high quality needs to be, is this care medically appropriate? So are we getting the right care to people? Is it culturally appropriate? And also, does it take into account, where is this person going back to? What is their home situation? And even if we can't address in this commission social determinants of health, at least doctors and healthcare providers can take that into account when they're thinking about medication adherence. Or do you need a home visit? Or do we need to make sure, if there were copays, you waive the copays for insulin so people can afford it? I mean, I think that aspect of thinking of the patient outside of the office will help with equitable provision of care, along with workforce. Workforce has to be trained on how to deliver it too. Sorry, Anthony, you can have my 30 seconds.
All right, Anthony, final statement, and then you get the big room too. So
Yeah, don't know how I'm going to summarize all this. I do agree that talk about quality, we talk about a lot of different things. We talk about quality of actual provision of care. I think there's a difference between that and quality of coverage and the quality of a person's experience. And I think that's also different for actual quality in terms of actual public health and actual outcomes. And I think we need to measure all of this. And again, I also just come back to the question of accountability. How do we use the levers that unified financing provides us to actually then hold the system accountable for those goals? That if we're not meeting those goals, then what? It's good to measure, but then what are the tools we use to actually then change behavior? Those are not tools we have very effectively right now. If anything, we have incentives in the wrong direction.
Great. Okay. Well, fabulous job. We're going to be moving back to the large group in about 3 seconds here. So see you back there shortly.